Hi, and welcome to the online lecture for cognitive and sensory alterations. I'm Judy Lokri. If you have any questions, please feel free to email me at jlokri@hcc.edu. The objectives for this particular class are to differentiate among the process of reception, perception, and reaction to sensory stimuli, discuss the relationship of sensory and cognitive function to an individual's level of wellness, discuss common causes and effects of sensory and cognitive alterations, discuss common sensory and cognitive changes that normally occur with aging, identify factors to assess in determining a client's sensory and cognitive status, identify some nursing diagnosis relevant to clients with sensory and cognitive alterations, develop a plan of care for clients with sensory and cognitive deficits, list interventions for preventing sensory deprivation and controlling sensory overload, describe conditions in the healthcare agency or client's home that you can adjust to promote meaningful sensory stimulation, and discuss ways to maintain a safe environment for clients with sensory and cognitive deficits. The first thing you need to look at when you are understanding what sensory and cognitive alterations are is actually what that means. So we have the definitions here is cognition. Cognition is knowing, influenced by awareness and judgment. It is composed of skills that include language, calculation, memory, attention, reasoning, learning, problem solving, and decision making. Sensations comes from many sources, in and outside of the body, through the senses of sight, which is also known as visual, hearing, also referred to as auditory, touch, also known as tactile, smell, referred to sometimes as olfactory, and taste, sometimes referred to as gustatory. Other definitions you'll need to know that are in relation to cognitive and sensory are aphasia. Aphasia is unable to produce or understand language. There are different types of aphasia, and it's not limited to these two types, but these two are more important for you to understand in this particular lecture. Expressive aphasia, which is motor type, inability to name common objects or to express simple ideas in words or writing. Receptive aphasia, which is sensory, inability to understand written or spoken language. And autotoxic is another terminology that you might hear related to sensory. And autotoxic is a particular chemical drug that may cause permanent damage to the auditory nerve. Other definitions that you need to be familiar with is kinesthetic sense. So the body has a kinesthetic sense that enables a person to be aware of the position and movement of the body parts without seeing them. That's you close your eyes and you're able to put your finger to your nose, you're able to put your hands by your side, and you know the position that they're in, and you don't have to see them. Stereognosis is a sense that allows a person to recognize an object's size, shape, and texture. And you probably notice sometimes when they do a neurological assessment or extensive one, they might have a blindfold on you and they have you identify the object that they give you in your hand. If it's a feather, if it's a baseball, you're able to identify. That's called stereognosis. There is a cognitive sensory relationship, and it refers with the brain and the neurological system or the central nervous system and peripheral nervous system as well. However, we're going to talk about in particular what happens with your brain and in particular in your cerebrum. The cerebrum is divided into 4 lobes: the frontal, the parietal, the temporal, and the occipital. The frontal is responsible for voluntary motor function, short-term memory, goal orientation, and eye movement. The parietal is responsible for receiving, analyzing, and responding to somatic sensory input from different parts of the body. The temporal is responsible for auditory stimuli, as well as long-term memory, balance, taste, and smell. And the occipital is responsible for processing visual information. So you can tell that if someone has an injury to any parts of those brains, you can almost understand, oh, they hit the back of their head, they have a problem with their occipital lobe, they're having problems processing visual information, and so forth, so on and so forth with the other particular ones. Scientific knowledge base is important for you to understand. There is normal sensation, which is normal sensation consists of reception. What is the stimulating factor? The stimulation of a receptor, which means light, what touch, any sound that you hear. Perception is the integration and interpretation of the stimuli, how you perceive that receptor or that stimulating factor. And reaction is how you react to it. You're only going to respond to the most important stimuli. So the most important stimuli will elicit a reaction. Cognitive impairments. Symptoms of cognitive impairments include being disoriented, loss of language or simple arithmetic skills, poor judgment, and also memory loss. Some cognitive alterations, we're going to just touch on them briefly here. You'll learn more about them and in more in depth next semester. But delirium, which is a reversible state of acute confusion, it's characterized by a disturbance in consciousness or a change in cognition that can develop over 1 to 2 days and is caused by a medical condition or procedure. Depression is a mood disorder characterized by a sense of hopelessness and persistent unhappiness. The symptoms interfere with daily living. Dementia is a permanent decline in mental function and has a subtle onset. It is characterized by a decline in many cognitive abilities, including reasoning, use of language, memory, computation, judgment, and learning. Brain injury and illness consists of traumatic brain injuries, cerebral vascular accidents, also known as CVAs or strokes, and some infections such as meningitis, and you've probably heard more recently about Eastern equine encephalitis or any type of encephalitis can impair cognitive and sensory functioning. Sensory alterations. You can have sensory deficits, the deficit in normal function of a sensory perception and perception. So you could be sensory deprived, which means there's an inadequate quality or quantity of stimulation, or you could be sensory overloaded, which means there's a reception of multiple sensory stimuli. So those are important to remember. The deficits that you can have obviously are with each of the senses. So you can have visual deficits. Visual deficits that you typically see are presbyopia, which is a gradual decline in the ability to focus on close objects, as you see with people who get around the age of 40 and older. You'll see them using reading glasses where they never had to read them before. Cataracts, that is cloudy, opaque parts of lens that cause blurry vision and glare. Glaucoma, which is an increase in interocular pressure, that's what IOP stands for. That results in peripheral visual loss and decreased visual acuity. Diabetic retinopathy, which is a pathological changes, which results in decreased vision or vision loss due to hemorrhage and macular edema. And macular degeneration, which is macular cannot function effectively. There's blurring of reading, there's distortion and loss of central vision in vertical lines. And in this slide right here, you will notice that it gives an example of what someone might see if they were experiencing some of these conditions. The first picture, of course, is of someone who has normal vision. The second picture, letter B, is a person who has a cataracts. This is how their vision may appear. Someone who has glaucoma is losing their peripheral vision, so their vision will appear more like the picture in letter C. Someone with diabetic retinopathy, remember they're having bleeds in the retina and they're having edema, and it blocks those areas where the bleeds have occurred. So that's this in letter D, what their vision might appear if they suffer from diabetic retinopathy. And E is age-related macular degeneration, where they're losing their central vision. Hearing deficits. So there is a condition called presbycusis, which is a common progressive hearing disorder in older adults. So you notice that older adults, especially being in the long-term care, you notice that you have to speak louder or more, pronounce more distinctly so that they're understanding what you're hearing. That is a common thing that happens. Cerumen accumulation is also something that can happen in any age group, and that's a buildup of earwax in the external auditory canal. The cerumen becomes hard and collects in the ear canal and can cause conductive hearing loss or conduction of deafness. And that is a reversible type of deafness, where if you remove the wax, you'll be able to hear. There also is equilibrium deficit, that is dizziness and disequilibrium. That's a common condition in older adults. It usually results from vestibular dysfunction. It frequently is caused by a change in position of the head. A change in the head precipitates it. And they experience an episode of vertigo or disequilibrium. This taste deficit, xerotomia, which is a decrease in salivary production that leads to thicker mucus and dry mouth. This often interferes with the ability to eat and leads to appetite and nutritional problems. And you probably see that with some of the elderly. They're not hungry. They're not eating as much. They're much thinner. Their taste buds, their saliva, they're not enjoying the food. It doesn't have the taste that is as enjoyable. We also have to look at neurological deficits, which relates to tactile. So tactile is touch. So if someone has peripheral neuropathy, they will have a disorder characterized by symptoms that include numbness and tingling of the affected area, and they might have a stumbling gait because they can't feel that sensation and it's numb. Stroke can also cause neurological deficits, which could cause tactile as well as visual, as well as hearing, as well as a lot of different aspects. But a stroke is usually caused by a clot or a hemorrhage or an emboli, disrupting the blood flow to the brain, causing permanent damage in that area that had the lack of blood flow, which it can result in altered proprioception, which means understanding where things are located in the body, because a lot of times they have hemiparesis or they can't use one half of their body. They may have marked incoordination and imbalance. They may have a loss of sensation in motor functions and extremity, and controlled by the affected areas of the brain. Effects of sensory deprivation. So if someone is deprived of any type of sensation, you will see that they'll have a cognitive decline. They'll have a decreased capacity to learn, an inability to think or problem solve. They'll have poor task performance. They might be disoriented. They might start being bizarre thinking. They will have a weird affect. They're going to be bored. They're going to be restless. They're going to be anxious. They might have emotional liability. They might panic, and they might have an increased need for physical stimulation. And think about someone who might be in solitary confinement. How scary that must be in darkness and no light, no sound, how someone might react with that particular sensory deprivation. That's an extreme case, but that's an example. Effects of sensory overload. The person will have difficulty focusing and decreased ability to learn. They might be extremely irritable, restless, and discomfort, anxiousness, fear, and stress about surroundings. And think about someone who's in the ICU, where there's so much going on, there's so many monitors, and they're stressed out, and they are anxious, they're irritable. So you will see that in some people in the ICU or in other areas where they have sensory overload. Other effects of sensory deprivation and overload, of course, are perceptual. They might have changes in visual or motor coordination. They might have reduced color perception, less tactile accuracy, changes in ability to perceive size and shape, and changes in spatial and time judgment. Factors affecting sensory and cognitive functions. Well, age. Age is definitely, as you age, a lot of your sensory sensations are affected, but it can also be affected by genetic factors, and it doesn't necessarily have to be an old person. It can be affected by the way the care was prenatally, or even postnatal conditions. And again, we talked about presbyopia in an earlier slide. Presbyopia is loss of near vision or inability to focus near, because your lens is changing size, and it usually occurs at the age of 40 and older. And they need reading glasses to be able to see up close. You also see people more prone to glaucoma. They have reduced visual fields. They have increased glare sensitivity, might have impaired night vision, reduced depth perception. So those things occur with age. Also, it has to be meaningful stimuli. If it's not meaningful, if someone is redundant, as you'll notice, if someone's really robotic speaking, sometimes, and you're thinking of something else and doing it, that stimuli might not be meaningful to you, and you're not hearing them. And hopefully that's not happening with me reading this particular PowerPoint to you. But other things, something that's meaningful, a pet's barking, music that you love, TV, picture of family members, oh, you're wondering what the time is. Those are meaningful stimuli. You might be hearing the clock tick. If it's not meaningful to you, you may not notice it. Amount of stimuli. Is it overload? Are you having too much noise? The fireworks going off, babies crying, so many things that are making it's overloading. You can't concentrate. Social interaction, and you see this oftentimes with people who are, as they age, families are busy, then the older person feels isolated, they're lonely. That can lead to anxiety and depression. And notice it in the long-term care facility with the elderly, even though they might have, the nursing people there, the CNAs and the nurses, they might still have loneliness and feel isolated because maybe their family's not visiting. Take that into consideration, and you can use that in your nursing care to help prevent that decrease in or factor affecting their sensory. Environmental factors can also affect, such as occupation, noise, repetitive movement, and cultural factors can also affect it, your ethnic background and your racial differences. Health assessments. So we're going to do a questionnaire and we're going to ask some questions. And I'm not going to read all of these, but these are important. Please look over this slide when you have an opportunity and read these things. These are important for sensory. Can you feel the difference between hot and cold water? Have a sore in the leg that hasn't healed? And so on and so forth. Do they have a hearing exam? Do they have an eye exam? Do they wear glasses? Is their vision blurry? Some other assessments, people who are at risk. When you are doing an assessment as on a person and you just met as a patient, you're going to look, are they confined to a wheelchair? Do they suffer from poor vision and hearing? Do they have decreased energy? Do they avoid others? Are they acutely ill? Are they unfamiliar or unresponsive with the environment? And that's really something that you're going to see a lot within the hospitals. Do they have any alterations? What's their history? Are they blind? Are they deaf? Do they have other symptoms? What's the nature of their problem? What are the signs and symptoms? When was the onset? How long has it been going on? And is there something that predisposes them to these conditions? Their mental status, physical appearance, behavior, cognitive ability, their emotional stability. Physical assessment. You're going to do a physical assessment. You want to do the vital signs, right? You're learning head-to-toe assessments. You're going to take their vital signs, see what those are like. Your neurological assessment, you've all learned how to do that. Are they alert and oriented times 4? Are they not? What's going on? Can they hear you? Can they see you? Can they smell? Can they taste? Are they able to discern difference between touch, between sharp and dull and soft and hard? The temperature, can they feel hot and cold? Do they feel pain and in what position? Are they able to perform self-care, feeding, dressing, grooming? Do they wear eyeglasses? Are there any environmental hazards, especially if you're doing home care and someone is older or they have sensory seeing difficulties or balance difficulties? You want to make sure that they don't have throw rugs, that the lighting is good, that there's nothing that they can trip on, that they have handrails they can grab on, things like that. Basic neurological assessment, which you just talked about, you want to do that. Assess the level of consciousness. Is the person awake, alert, oriented? Are they agitated? Are they lethargic? Check the pupils. A good way to describe pupil reaction is that pupils are equal, round, reactive to light, and accommodate. That's often abbreviated with PERLA, P-E-R-R-L-A. Sometimes you'll see it referred to as P-E-A-R-R-L-A or L. So they are referred to that. Most places that I see do the P-E-R-R-L-A, but you will see it other ways as well. Assess for hand grasps and leg strengths. Assess for sensory. Can the patient detect the difference between warm and cold and sharp and dull? And more advanced practitioners will do a more in-depth one, which would be deep tendon reflexes. Another assessment, you want to look at their speaking and understanding. Their social support. Do they live alone? Do they have family? Do their friends visit or family visit? Do they use assistive devices and how often? Do they need cleaning? And do they have any problems with that? Other factors, they might have medication or pain that could affect their sensory. Some nursing diagnoses. After the assessment is completed, after you've done everything and you've seen that they may have some risk factors, you need to plan. You need to find something, what it is, if there is a problem, and then come up with some goals or outcomes to help with that problem. Some example nursing diagnoses that someone might have is disturbed sensory perception, auditory or visual, impaired verbal communication, risk for injury, impaired physical mobility, social isolation. Of course, we're not limited to those nursing diagnoses, but these are some of the more common nursing diagnoses that you might see with someone with cognitive and sensory alterations. Goals, an example, the client will achieve improvement in hearing acuity within 2 weeks. The client will report using communication techniques for improved reception of messages within 2 weeks. The client will successfully demonstrate techniques for cleansing hearing aid within 1 week. These are just examples of someone obviously who has a hearing difficulty. Implementation, we do health promotion, you're going to do screening, preventative safety, use of contact lenses, eyeglasses, hearing aids, promotion of meaningful stimuli, and creating, of course, a safe environment. Acute care, when you're taking care of someone who has some type of sensory deficit, you're going to try to orient the patient to the environment, address the client by name, place the call light within reach. These are all things you know. Use a night light and reduce clutter. controlling the stimuli. You want to reduce sensory stimuli or overload. Combine nursing activities and control extraneous noise. Some restorative and continuing care. You want to make sure there's socialization, that they're able to communicate. Do they have physical contact? Do they have mutual groups that they can involve in? We also want to promote self-care. That helps increase self-esteem and safety awareness. And then after you're finished with all that, you want to make sure that these things have come through, and you want to evaluate the client. Is the client the only person really who can tell you if sensory ability has improved as a result of your nursing interventions? So whatever the problem is that you are dealing with, or the client is dealing with, you're going to come up with a nursing diagnosis that's appropriate to it. The example that we had was for hearing for goals, but there could be any type of sensory deprivation. And what are you going to come up with that would help, that you want to reach a goal, and what interventions can you do that will help with that sensory deficit? And once you've implemented those interventions to help, did they work? The client is the one and the only one who can tell you what their perception is. So again, this is the sensory and cognitive online lecture. And if you have any questions, please feel free to email me. Thanks.